So this is a report of a first-in-human study of a drug, VS6766. It's an unusual drug because it inhibits MEK allosterically, but also functionally inhibits the signaling from RAF to MEK, which is not present in a lot of MEK inhibitors. And the other very interesting part of this trial was the fact that it's given intermittently, only twice a week. So the MEK inhibitors are very rarely, or in fact, to my knowledge, have not been dosed in such an intermittent fashion before. And probably the most important part of the trial, and it is the fact that we have seen clinical responses which have been durable in patients with KRAS mutations, and it's a huge area of unmet need. And we hope this is the beginning of a set of clinical trials that will benefit patients in the future.
What are the most common questions your colleagues ask you about this study?
So I think the first question people ask us is that, what tumor types have you seen the responses in? I mean, that's all oncologists want to help their patients, so that's the first thing they ask. And why haven't we heard of this before? What indications does this drug work in? So clinically, what we've seen so far is it's an area of unmet, KRAS mutant cancer is an area of unmet need. Sort of, I guess, press and good news about certain drugs which inhibit specific types of KRAS mutation, G12C mutation. So there's a lot of academic literature now emerging. However, what is very interesting in this clinical trial is that we've seen response in KRAS mutations which are not G12C. But that's still a large number of patients. So that's the first aspect. And the second aspect, in the tumor types we've seen in this particular trial that we've reported, we saw responses in patients with KRAS mutant lung cancer, again in patients who did not. We also saw responses in patients with gynecological cancers, which typically with RAS mutations are low-grade serous ovarian cancers, but also endometrial cancers, endometrioid ovarian cancers. And in this study, we've even seen responses in, rather unusually, in multiple myeloma, but again with RAS mutations. In addition to these solid tumors and KRAS mutations, we've also seen response in a patient with an HRAS mutation, which is a rare mutation. However, again, there are no targeted clinical drugs against these.
Will this data affect clinicians today? And if so, how?
So currently the next step, it has been, with these drugs, it has been very important to get to a tolerable dose, which can be used as a single agent and in combination in the future. So that was the main aim of this particular study. It's a phase 1 study. Of course, the icing on the cake is lots of patients have responded, and we're very, very happy about that. But it has set the backbone of combination studies and single agent studies. I think for doctors to be more widely, it will need further studies, which are phase 2, and hopefully one day phase 3 studies, which are currently planned. So I can ask John to sort of update you on what studies are planned. But currently we have a few studies which are still cementing what we've seen so far in combination. However, for larger phase studies, we'll need to open before patients and doctors have access to this more freely. So John, I don't know if you want to comment on.
Yeah, sure. So some of the signals from Dr. commenting on the single agent study that was just reported in Lancet Oncology, and also the combination with our FAK inhibitor. Clearly in both studies, we're seeing exciting activity in low-grade serous ovarian cancer, which tends to be a RAS-driven subset of ovarian cancer, as well as lung cancer, especially with KRAS G12V mutation. So based on Dr. Banerji's work, Verastem is starting registration-directed trials. The intent is to start them this year. One in low-grade serous ovarian cancer, which we've discussed with the FDA, and also in KRAS G12V mutant lung cancer. So we're very excited about these as potentially leading to registration of VS676 alone. And we're also testing it in combination with our FAK inhibitor, defactinib, and then we'll determine which is the regimen to go forward with. And very importantly, we're using this intermittent dosing schedule that Dr. Banerji mentioned, and we think it's really important here for having both activity with tolerability, so that's really key in this field. In addition, just briefly, Dr. Banerji is starting cohorts in other KRAS-driven diseases, pancreatic cancer, KRAS mutant, to see what VS6766 as well as the FAK inhibitor combination do in those diseases.
So my last question here was, what is the next step for this research? But we kind of just dovetailed right into that, which worked out really well. So I'm just going to end with, if either of you have any last closing comments to make, and since I already see John on my screen, so I'll start with John, and then Dr. Banerji, if you have any closing comments, please jump in as well.
Shortening in the RAS pathway field is the need for what's called vertical inhibition. So if you picture RAS, RAF, MEK, ERK as the pathway, what people are finding is you need to block more than one of those targets at the same time for durable inhibition for benefit for patients. And what we believe is that 6766, by hitting RAF and MEK, is probably the only drug that we know of that can do that in one molecule. So that really enables it potentially to be a backbone for therapies for RAS-driven cancers, but also it opens up the door to G can talk about what he's doing with an mTOR inhibitor, but we're also looking potentially at other combinations as well for RAS-driven cancers, and our hope is that there could be different combinations for different cancers where VS6766 is in the middle of all of that.
Sure. So I think just to add to that, scientifically, MEK is a very important node, and so and as an activating mutation, so is KRAS. So there are multiple downstream pathways and upstream pathways if they're feedback loops. So we have certainly seen in clinical trials, if you use a MEK inhibitor, you can get upregulation of phospholipid with a FAK inhibitor is interesting, and we've shown that in clinical trials. Also, one of my sort of areas of research has been feedback loops and proteomic mechanisms or plastic mechanisms of resistance to MEK inhibitors. And certainly the PI3 kinase pathway is an important one. So we are also got a clinical trial running where we are combining everolimus with 6766. And that is also, the results of which are obviously awaited, but I'm very excited about the potential for combination. So I think that there are multiple places this drug can be used. We've only surfaced in terms of other RAS mutant cancers or even hematologic malignancies like myeloma. So, but you have to sort of pursue these logically. So we're doing one step at a time. We're doing the defactinib combination, the everolimus combination, and I think once more academics and other oncologists get sort of involved in this, I'm sure there'll be other ideas which we haven't thought of, and I'll be very. It's for patient benefits. So I'll be happy if any form of further academic input and collaboration reaches its eventual goal to try and help patients.
This was a really wonderful interview, and I think this will make a really nice video. So thank you all so much for your time, Dr. Banerji, John, and of course, Karen, for coordinating everything wonderfully. As always, this was great.